Hi, everyone. I'm Arjun Masurkar. I'm one of the cognitive neurologists here at NYU. I also play a role in the Alzheimer's Disease Research Center where I direct the clinical core, and that's how I've met some of you here in the audience. And so I'm really glad to see some familiar faces, and I'm really glad to see some faces I haven't seen before. I'm hoping to interact with you, afterwards. So I think I'm really excited to hear and learn from my colleagues at NYU and at the Alzheimer's Association, and I'm very enthusiastic about this collaborative effort today. And I hope it's just as rewarding for all of you. So please, enjoy, and we hope to have some great questions later on. Thank you.
Excellent. Thank you so much. And while we welcome all of you here physically in the room with us, I know last I looked, there were 25 or so folks joining us online, and I have no doubt that that number is ticking up. So we're glad you're here, however you are joining us. Before we get started with our first speaker, we wanted to share some foundational information so we all understand the impact and prevalence of Alzheimer's and other dementia. We are one of the proud co-hosts of today's event, and our mission is to lead the way to end Alzheimer's and all other dementia by accelerating global research, driving risk reduction and early detection, and maximizing quality care and support. Now, many of you may have come to this program being connected through research. You may have been connected through our care and support programs or some of the support services that you're getting through NYU. But at the Alzheimer's Association, we want to make sure that today we're focusing on that research area of our mission. It's important to know that the Alzheimer's Association is the world's leading nonprofit funder of Alzheimer's and dementia research. There are currently active grants of over $405 million, funding more than 1,100 projects in 56 countries around the world. And then to give you a snapshot of what that looks like here in New York, as you all know, we have a number of fantastic academic institutions here in New York City, of which NYU is one of them. In New York State, we're funding 378 awards over the last 30 years, math, totaling close to $78 million, listing some of the different beneficiaries below. So a lot of the research you're going to hear about today was funded directly by the Alzheimer's Association. And then you'll also get to hear about the amazing work being done here at NYU. So with that, it is now my pleasure to introduce today's keynote speaker, Dr. Rebecca Edelmayer. A Senior Director of Scientific Engagement for the Alzheimer's Association, Dr. Edelmayer leads efforts to accelerate the organization's scientific agenda through the creation and delivery of ongoing research education. She engages with chapters, just like ours, all across the country, ensuring that communities are informed of the global progress of dementia science and the organization's crucial role in advancing research to improve the lives of those facing Alzheimer's and all other dementia. She provides leadership of the association's national and international initiatives in dementia science, uniting researchers and clinicians on topics related to biomarker testing, drug discovery, and therapeutic development. She also serves on steering committees and as an external advisory board member for various cutting-edge scientific consortia established by the NIA to advance treatment development. She has more than 20 years experience as a scientist and educator, completed her PhD and postdoctoral training in medical pharmacology at University of Arizona College of Medicine. And she holds a bachelor's degree in neuroscience from the University of Pittsburgh, where she also completed a National Institutes of Mental Health Research Fellowship. Thrilled to welcome Dr. Edelmayer today to provide us with an overview of research advances in Alzheimer's and all other dementia. Dr. Edelmayer, the floor is yours.
Hi, everybody. How are you this evening? It's so good to be here with you all. I love being back on the East Coast. I'm originally from the Pennsylvania area, so come to New York very, very frequently, and it's just a pleasure to be back in town. I consider New York one of my second homes. So I think, as Melissa pointed out to you today, we are really excited to bring to you, I think, a lot of the groundbreaking work that's happening across the globe. And it's hard to do that in 30 minutes. So what I'm going to try to do is set the stage for you of what's happening in Alzheimer's and dementia science, what's happening across the world, really, and how the association is also playing a role in helping to fund some of that research. So we weren't able to see the video for our facts and figures, but it's a really important document that we create every year as an organization. Our facts and figures report, our Alzheimer's disease facts and figures report, is produced every year. It's one of the most cited documents in our field. It really helps to bring together a lot of facts, statistics about Alzheimer's disease and other types of dementia, so people can learn more about these particular diseases and understand how it's impacting all of our communities. We know that there are nearly 7 million Americans today that are living with Alzheimer's. We know that 1 in 3 seniors dies with Alzheimer's or another type of dementia. And we know that it really impacts our communities beyond just those living with Alzheimer's or another dementia, but also the caregivers. There's over 11 million Americans providing unpaid care for people that are living with Alzheimer's disease or another type of dementia. And there's more work that we need to do to continue to make sure that people have access to clinicians that are trained to detect and diagnose Alzheimer's disease and other dementia. We need to make sure that there's ways that we can help to treat all sorts of individuals that are living with Alzheimer's disease and other types of dementia. And we need to continue to do research that helps us to improve care, as well as the health equity in how we serve our communities. So I do want to set the stage for all of you today in terms of some language that I want to cover before we even start. One of the biggest questions that I get as a researcher in this field is, what is the difference between Alzheimer's and dementia? And so I like to use this analogy. When we talk about the term dementia, it really is an umbrella term for a collection of symptoms that someone might experience that are associated with changes in their cognition, like memory and thinking, changes in their behavior, that could be anxiety or even sleep disturbances, or changes in psychological symptoms, that could be maybe hallucinations or delusions that are existing. Alzheimer's disease is the most common cause of the symptoms of dementia. So dementia really is the consequence of these diseases. But there are other types of diseases that cause dementia: vascular contributions or vascular changes in the brain, Lewy body disorders, frontotemporal disorders, and other types of diseases that cause changes and really death to the cells in our brain, like the neurons and the immune cells that are really important for keeping us functioning appropriately. So not everyone with cognitive decline actually has dementia. There are many types of changes that can happen in the brain and the body that can cause someone to have issues with their memory or thinking. And it's really, really, really important that people get to the underlying cause of those changes. So, for example, sleep disturbances can cause changes in our memory and thinking. Side effects from other medications can, metabolic disorders. All of these need to be investigated to truly understand what is the underlying cause of the symptoms of dementia. And there's a lot of research ongoing across all of these different types of diseases that cause dementia today. I do want to focus on Alzheimer's disease. So when I say the underlying changes that are happening in the brain, I'm talking about some of these key hallmark changes in Alzheimer's. Now, these are 3 changes that we know exist, but there are a variety of other changes that are also happening in the brain that we'll cover today too. The 3 changes I want to touch on are the amyloid plaques or beta amyloid. You might hear this a lot about amyloid plaques in the brain. This is a change in a protein called amyloid, and it tends to build up. Sometimes it even looks a little bit like a cloud like this around the outside of the cells, and it can cause deterioration in the cellular health. There's something also called tau protein. So Phosphorylated tau in the brain is something that causes tangles of this protein up inside the cells that can cause also a decrease in how cells can talk to each other, and really decreasing the function of the cells over time, causing death to the brain cells in areas of our brain that are really, really important for our memory, our thinking, and some of our behaviors. So the brain tissue itself actually shrinks, and you can see this on MRI scans that are done through different types of brain imaging. Another thing I want to touch on is that Alzheimer's disease and other types of dementia occur across a continuum. Many different phases to these diseases, and everyone progresses at in different ways. They also progress at different speeds. And one of the things that it should be clear, I hope, by the end of my presentation today, is that Alzheimer's disease starts way before people start having symptoms. There's a phase of the disease called the asymptomatic phase. That's a phase where you don't have any changes to your cognition or thinking that are necessarily measurable, but you may have changes to some of those underlying biology associated with Alzheimer's, like the amyloid plaques and the tau tangles. And this can occur maybe up to 20 years before anyone even starts experiencing symptoms. Another phase of the disease is called mild cognitive impairment. This is a stage of the disease that is defined as symptoms that are starting to affect activities of daily living. You would actually see changes in any type of cognitive and functional tests that may also be given. Now, mild cognitive impairment is a phase of Alzheimer's disease. It doesn't necessarily mean you're going to develop Alzheimer's disease, but it is a risk factor for it. So individuals that are living with mild cognitive impairment due to Alzheimer's disease are already starting to see some changes in their memory, maybe their thinking, maybe their executive function or planning. But they may also then have changes in their brain that are associated with Alzheimer's. So they would have to have plaques, maybe even some tau tangles in the brain to be at this stage. But then when you go on to develop dementia, mild, moderate, severe dementia, these are stages of Alzheimer's disease that are progressively more serious. The symptoms interfere with more and more activities of daily living, and people start to lose their independence more and more over time until activities are interfered almost completely, and people require really round-the-clock care at all times. So let's talk a little bit about understanding risk for Alzheimer's disease and other types of dementia. There are many factors that drive each of our risk for developing Alzheimer's disease. Age happens to be one of the biggest risk factors for Alzheimer's. It's not the only factor, though. Genetics and family history, shared family lifestyle can also play a role. And those are not necessarily things that we can change easily. I wish I could roll back the clock on my age, for sure. But the things that we can potentially change, the things that we could adjust across our life course, there's an enormous amount of research that's focused on this today, trying to understand what those modifiable factors could be. And we want to be able to think about how we can reduce our risk in each individual, in each population, in each community. And so there's an enormous amount of research ongoing to try to understand the different types of habits that we could adjust, the ones that would be most important for our cognitive and brain health across our life course. We know today, based on some of the research, that there are positive actions that people could be taking to potentially make a difference in their brain health, even potentially lowering the risk of cognitive decline and possibly even Alzheimer's and dementia. But there's a lot more work that still needs to be done in this area. There are some that estimate that possibly up to 40% of dementia cases could be prevented or delayed by targeting some of these modifiable risk factors. Things like improving our cardiovascular health, staying up to speed with our education, eating heart-healthy diets, being smoke-free. Some of these types of things have been studied in large clinical trials and through large observational research studies. One of the things that I do want to point out about this sort of pinwheel that you're seeing here is that the research that we have that backs up this data is not all created equally. We don't have strong information for all of these particular associated modifiable risk factors, but some of the strongest data that we have today supports better management of our cardiovascular health. What's good for your heart is going to be good for your brain. So that means eating heart-healthy diets, staying physically active, and keeping up with your heart health numbers and really trying to control things like diabetes and other types of numbers associated with your heart health. we do see that most of the research is suggesting that combining multiple health factors may be the most impactful. One of the things I should point out about this, though, is that we know that it can be difficult to change some of these things. And social determinants of health are something that we are following very, very closely to be able to truly understand how each individual, how each group is affected by those types of things in their life. Access to quality food, access to safe environments to exercise. These are the types of strategies that are also being studied, because for us to create sustainable strategies for risk reduction, we need to understand what we need to do across our communities and the type of infrastructure we need to build to make sure people can adhere to those types of, to the doctor's advice when they're receiving that in the office. So there's a lot of research ongoing, as I noted, in this space. And one of the studies that we are doing as an organization is really key, a landmark clinical trial called the US Pointer Study that's really looking at trying to understand how we can intervene across our lifestyle to reduce our risk. The US Pointer Study is a multi-domain lifestyle intervention where we're studying people who are getting an intervention that looks at better management of their heart health, better management of physical activity, nutrition, as well as social and cognitive engagement to see if we can reduce risk in individuals for developing Alzheimer's disease or another type of dementia. The goal is to really target these multiple factors at one time to try to understand if we can reduce an individual's risk. And if the trial is successful and what we learn from this study will help us to really create a sustainable and accessible community-based program for dementia prevention. We're running the US Pointer Study across 5 sites in our country, in North Carolina, Chicago, Texas, and California, and also in the New England area. And one of the things that's most important about the US Pointer Study is that we've actually enrolled over 30% of that study from underrepresented populations, people who have historically not been represented in these types of studies, because we need to make sure that the learnings that we have from this research trial will actually benefit all individuals. The US Pointer Study is actually part of a much larger research network called the Worldwide Fingers Network. And I don't know if you're catching the puns here, but we've got the fingers, we've got the pointer, we actually have a thumb trial that we're trying to build in Canada. I'm not sure where that started, but I think it's actually kind of fun. But this is really a global network that's looking at lifestyle intervention studies, not drug studies, but lifestyle intervention as a mechanism to reduce risk in over 60 countries across the world. And we help to convene researchers and bring them together to talk about how we can harmonize our learnings from all of these different studies across the world and share experiences. Because we know a diet in India is not going to be the same in Japan, is not going to be the same in the United States, but a heart-healthy diet or a brain-healthy diet and what we can learn from these types of studies will be key to share with our communities. So I want to now touch a little bit on early detection and diagnosis and why this is so important. I mentioned this early in my talk. We know that there are many benefits of an early and accurate diagnosis. We know there's medical benefits, emotional and social benefits, as well as financial benefits for individuals. Some of the medical benefits are really critical, especially right now. We're moving into a new era of diagnostics and treatments. Access to current treatments is critical. Making sure people are getting an accurate diagnosis is critical. Opportunity to participate in clinical trials. This may be really important, especially for individuals who are living with a disease where we do not yet have an effective treatment. And we have to continue to do that research to make sure that we create treatments that will benefit everyone. And it allows us time to prioritize other health factors, including making lifestyle changes, including controlling chronic health conditions that may also contribute to our decline and the decline of our health. And there's a lot more time to plan for the future, have conversations with family, friends, time to plan for end-of-life decisions, and thinking about how we can save costs for everyone. As we know, Alzheimer's disease and other dementia are enormously costly to families as well as our society. So I want to touch on where the field is going. And first, I'm going to start with a concept of biomarkers. Biomarkers are really changing the game for Alzheimer's disease and other dementia. You actually all are very familiar with what biomarkers are, but we haven't talked about them a lot for Alzheimer's disease and other types of dementia. A biomarker is really just a way for us to measure biological change in our bodies. So these are really meant to be reliable predictors and indicators of disease or disease progression or predictors of your health. And so, for example, many of you have gone and gotten a blood test on a regular basis at your primary care doctor's office. They're measuring glucose as a biomarker for understanding whether you have insulin resistance or diabetes. They're measuring cholesterol to understand your heart health and your risk for heart disease. And you know, from some of these types of biomarkers, doctors will actually take multiple markers together, like for cholesterol, for example, LDLs, HDLs, your triglycerides, and it helps to paint a picture of what's going on in your body. But we need these types of tools for Alzheimer's disease as well. We can't just go off of the way people are experiencing symptoms and changes in their functional activities of daily living. We need to actually understand what's going on in the body. And so we can use biomarkers in Alzheimer's disease as a way to diagnose, to maybe help enroll people in clinical trials, maybe to determine the course of your illness or follow treatments over time, and even to look at and track outcomes of these treatments. The Alzheimer's Association actually funded research back in the early 2000s that helped to develop one of the first biomarkers for Alzheimer's disease. And that is the development of the first amyloid PET tracer that can detect amyloid plaques in the brain of individuals who are living with Alzheimer's disease. And this tracer was actually called Pittsburgh Compound B. I'm personally very proud of this one because I am an alumni of the University of Pittsburgh, but I've also met some of the researchers, Dr. Bill Klunk and Dr. Chet Mathis, who helped to develop this tracer. And it's used all over the world today. And it's FDA approved now and can be used in clinics. And there's now, I think, 4 other amyloid PET tracers that can be used to do PET imaging to look in a living brain at an individual that's living with Alzheimer's disease to understand if they have those hallmark changes. So we've really seen an enormous amount of progress that's happening in biomarker development for Alzheimer's disease. We saw and first developed an understanding about Alzheimer's disease back in 1906 by looking at tissue under a microscope. Dr. Alois Alzheimer, that's what the disease is named after, looked at the amyloid plaques and the tau tangles in the brain. But unfortunately, the only way to do this is after somebody passes away. And we need those types of tools in individuals who are still living or at risk for developing Alzheimer's disease. It wasn't until the late 1990s that we saw the development of cerebral spinal fluid analysis. That's where they do a lumbar puncture and withdraw some of that beautiful fluid that bathes your brain and your spinal cord. And we can start to see that there are tools for us to see these markers like the amyloid beta plaques, as well as the tau tangles and what we call phospho-tau or p-tau in that particular fluid. It can be a reliable indicator of whether or not someone is actually having the development of amyloid plaques in their brain without even looking at their brain. In the mid to late 2000s, as we just talked about, amyloid PET imaging came about. Then we had mid to late 2010s, we had tau PET imaging, which both, there's actually FDA approved diagnostics for cerebral spinal fluid, amyloid PET imaging, tau PET imaging that are available today. And where we're really going, some of the emerging types of biomarkers, blood biomarkers. And this is a new space for us. If you asked me 5 years ago if we would have blood biomarkers for Alzheimer's disease, I probably would have said no. But this has rapidly been changing in just the past few years. And we're now starting to see emerging blood biomarkers, some already starting to be available in specialists' office to help aid in the diagnosis of Alzheimer's disease. And so when we look across all of these different types of biomarkers, the PET imaging, which stands for positron emission tomography, this allows the doctors to look inside the brain of someone who's living for a very specific marker, like the amyloid or tau, or you can even look at how cells are using glucose and sugars in the brain. There's the MRI scanning that can be done. That's helping to look at the structure of the brain and any of the changes, whether the brain is shrinking in areas of the brain that are really important for our memory and thinking. There's the cerebral spinal fluid analysis, as I just noted, and blood tests. And I think blood tests are really going to change the way we help to diagnose and treat Alzheimer's disease in the near future. Right now, they're being used and tested in clinical trials, many to help enroll people in clinical trials, and they're being used by specialists, by individuals that are trained to diagnose and treat memory disorders to help aid in that diagnostic process. They're not yet ready to be used broadly in clinical care, not yet ready for primary care doctors' offices yet. There's a little bit more research that we still need to do to make sure that the results are reliable that they're not giving people false positive and false negative results. But I think one thing that I do want to make sure that you realize is while blood tests may be the future, because they're going to be hopefully low cost, not invasive, something that's scalable around the globe, they're never going to be a standalone test for Alzheimer's disease. It's always going to require a thorough evaluation by people who are trained to diagnose memory and treatment disorders with both cognitive and functional tests, with other types of medical exams, imaging, potentially cerebral spinal fluid. All of this may be part of that diagnostic process. So this is really modernizing how we diagnose and treat memory disorders. We used to only diagnose people based on their symptoms and maybe a family history, but now we're shifting that because we know that the disease starts much earlier than when people start with symptoms. So this helps us paint a picture of how we will continue to understand Alzheimer's disease. We need to understand the brain changes that are happening. And for that, we need to actually develop biomarkers that can detect these different changes, not just for amyloid and tau in the brain, but vascular changes, changes that might be happening associated with inflammation or the immune cells in our bodies. We need to look at different ways we can develop those biomarkers. As we talked about, imaging and biofluid analysis are going to be key. That helps us to really get down into the true understanding of what's going on in the brain and what types of therapies are going to be most appropriate. And when you layer on modifiable risk factors and lifestyle intervention into this, this becomes a more complete picture of how we will most effectively treat individuals with Alzheimer's disease and other dementia. So why is early detection so important? That really means we need to understand the treatment landscape today. There are a number of FDA-approved therapies for Alzheimer's disease, and we've seen some incredible advancements in just the past few years. As I've just noted to you, Dr. Alois Alzheimer in 1906 first defined the disease, but it wasn't until the late 90s that we even had the first FDA-approved treatments for Alzheimer's disease. These first 5 treatments that you're looking at in orange, these treatments were designed to help enhance cognition. They treat the symptoms of Alzheimer's disease. They help the cells sort of talk to each other more effectively. And they work very, very well for many people. But they temporarily work because what they do not do is they do not necessarily slow down the disease process in the brain. So if the brain cells die, these types of treatments don't necessarily have cells to work on anymore, right? And so we need to continue to develop treatments that are actually going to slow down that disease process, keep the cells healthier for longer, and keep them alive for longer so that they can continue to communicate. So what we've seen most recently in 2020, we actually saw the first treatment for symptoms that we saw clinical trial results that were associated with testing people who were living with Alzheimer's disease to actually treat insomnia associated with Alzheimer's disease. That was one of our first symptomatic approaches for treating one of the behavioral issues that could be associated with Alzheimer's. We now have treatments that are approved to slow down the disease progression. In 2021 and in 2023, we saw the first 2 treatments that go after those beta amyloid plaques in the brain. And now these treatments really are going to have an effect on keeping those cells healthy longer because they're supposed to basically remove or help to remove the amyloid from the brain, which is aimed at then slowing down the disease progression and keeping the cascade of other events that are occurring in the brain, the buildup of the tau, the changes in inflammation, the changes in the immune cells from occurring over time. In clinical trials for both aducanumab and lecanemab, they were able to demonstrate when you remove the amyloid from the brain in individuals that have mild cognitive impairment due to Alzheimer's disease or mild Alzheimer's dementia, you were able to slow down disease progression. You're reducing the amount of cognitive and functional decline that people are having with the disease. This was done in an 18-month trial for both of these types of treatments. There's a lot more that we still need to learn about how these drugs are effective and safe in individuals for a longer period of time. I do want to point out one more treatment that was just approved in 2023. This was our first actual treatment that was approved to treat one of the most challenging symptoms with Alzheimer's disease, and that is agitation. We know this is one of the types of symptoms that is going to be ones that typically are at a later stage of Alzheimer's disease, and they can be present in many individuals with Alzheimer's and other types of dementia. And they can be one of the reasons that people end up being moved into long-term communities or long-term care communities because they're so challenging to treat. So having options for treatment are really, really important. But you can see we need way more options because these treatments are not necessarily going to be a right fit for everybody. It's going to be an important conversation with your doctor to understand if you're eligible for these treatments. And also based on other underlying health conditions that you may have, you may not be appropriate for these treatments. But as we continue to do the research, we know that there's treatments that are needed not only for all stages of Alzheimer's disease, but many different types of individuals so that we have options. So think about the options we have for cancer today, for cardiovascular disease today. We're just starting with Alzheimer's to make sure that those options are available. And as I noted, we're in a new phase of treatment. So I was just focusing on these new treatments that can help slow down the disease progression that were just approved in 2021 and 2023. But there are already new generations of these treatments that are already in research clinical trials today. We're waiting to hear about a third treatment. It was just announced, I think yesterday, that the FDA will be having a discussion with the manufacturers of this particular drug on June 10th to hopefully finish their review of this medication to see if it would be approved. And so aducanumab, lecanemab, and donanemab are all they're all amyloid targeting approaches. But as I noted, there are many different changes that are happening in the brain in Alzheimer's. And there's probably over at least at minimum 120 unique therapies that are being tested in clinical trials that target multiple aspects of Alzheimer's disease and other dementia biology. And this example just shows you that the amyloid and tau, we've been focusing on that a little bit, but that's just one part of this disease. We're talking about treatments that are looking at cellular communication, maybe how cells use energy, that's called bioenergetics, vascular changes in the brain, neuroinflammation. You may see very well in the future that individuals are taking a combination of very powerful, effective therapeutics. Maybe it's an anti-amyloid treatment early on in their disease stage. Maybe they get put on an anti-inflammatory type of approach to control neuroinflammation at later stages of the disease. All of this is being tested today. And so it's exciting to see that there are so many clinical trials ongoing. When you actually look at the 2024 Alzheimer's drug pipeline, this is just Alzheimer's drugs. This isn't even capturing medications for Lewy body dementia or frontotemporal dementia or vascular dementia. But as I noted, there's over 120 unique therapies today based on this report put out by Dr. Jeffrey Cummings and his team. Now, this just came out, I think, just last month. And it really points, I think, to a few key features here. There's over 164 different clinical trials just for these 127 medications that are ongoing today. We know that there are 33 new treatments that have entered the pipeline since last year. One thing I want you to focus on is this over 65,000 people are needed to participate in clinical trials to help us get to the end of these studies to understand whether or not these treatments could be safe and potentially effective in individuals with Alzheimer's or another dementia. And that's really key because we need everybody to be involved. And getting involved in research, we hope it's an easy process for you. And the Alzheimer's Association does offer an opportunity to do this. If you're looking to get involved in studies, what I just showed you was the treatment pipeline for Alzheimer's disease drug trials, but there are over 700 different types of studies for all different types of research that's ongoing in our field for Alzheimer's and dementia. And the Alzheimer's Association offers a product or a service called Trial Match. This is a free clinical trials matching service that you could use to look for studies that might be a right fit for you or your family. We have caregiver studies. We have testing new blood tests or even exercise trials or drug treatment trials that are listed here. And we need both healthy as well as cognitively impaired people to participate. And so I really encourage you, if you're looking for studies to participate in, I know there's many that are even happening here at NYU, and you might hear about some of those later today, but I think it's important for you to think about this as an opportunity to connect with a study. So let's talk about the future of Alzheimer's and dementia treatment, diagnosis, and care. So we've talked a lot about clinical trials. That's before things get approved by the FDA or before things are actually incorporated into public health strategies. What happens once those types of treatments are approved? Well, the Alzheimer's Association launched 2 years ago something called the Alzheimer's Network for Treatment and Diagnostics. We're moving into a new phase of research that now we can do in our field. This wasn't really possible before, but it's worked in other disease areas. And that's the collection of what we call real world data. So collecting information from people who are taking new treatments or using new diagnostics to help with getting them their diagnosis. So the Alzheimer's Network, or ALZNet, was launched in 2022. And this is really aimed at being a resource for clinicians to improve their care over time based on real world data that's coming from their patients into this clinical study platform. So ALZNet is what we call a voluntary healthcare provider patient enrolled network or registry. That means individuals would go to their doctor's office and they would get regular clinical care by their doctor. And the doctor themselves is actually going to ask if you'd like to participate in ALZNet. And you would allow or consent for your data to be shared into the ALZNet network. It's all de-identified to protect your privacy and health information. So none of it can be matched back to you. And it's a way for us to collect both clinical and diagnostic data like imaging results or other types of information so researchers can learn more about these treatments in broader populations. It's collecting information from people that are being evaluated for or treated with any of the novel or new FDA-approved treatments. So any of those treatments that were approved in 2021 or after. So that means amyloid targeting therapies, or like the brexpiprazole medication for agitation. We're also studying that too, and any new treatments that are approved thereafter. And the goal is that we're collecting information about treatments that are not only aimed at slowing down disease progression, but also those treatments that can help to enhance cognition or address neuropsychological or behavioral symptoms. All of these types of treatments are going to be studied in ALZNet. And it's really implemented in real world practice in real world doctors' offices after these treatments are approved by the FDA. It's not a clinical trial. And ALZNet's going to continue to evolve over time. So why did we launch ALZNet? The goal is that we know that clinical trials for Alzheimer's disease take a long time, and there's such an unmet need to make sure that these treatments, once approved by the FDA, get to patients that need them. But there's much more information that we still need, from understanding how these drugs work in broader populations and across different clinical care settings. And so we've built ALZNet to really help us develop what we call real world evidence. That's the RWE you see on your screen there. To understand how these types of new diagnostics and treatments are supporting not only the patients, but also how do we use this information to drive future innovative research for treatments. We can ask questions of ALZNet, like what is the long-term effectiveness of a treatment after 18 months? ALZNet is going to run for decades and decades. So a patient could participate in ALZNet for many years, starting a new treatment, stopping a new treatment, and they're getting evaluations by their doctors along the way. And this data is being entered into our system. We can look at long-term safety considerations. Who might respond well, who might not respond well to treatments. We could look at combination therapies. We could look at even people who are going to be taking a new treatment that's approved, but maybe they're also participating in a clinical trial. This type of platform and network allows us to do that. So there are already over 200 sites in various stages of activation and startup of ALZNet across the country. And actually, NYU Langone is one of the sites that's moving through their startup process. So this is something that may be available to you if you're seeing a clinician here at NYU. But there are a number of other sites in the New York area that are getting up and running. We have one, I think, already up and running in Brooklyn, and another site that's completely active, and they're already starting to collect patient information from patients who consent. So it's really exciting to see. We have over 50 sites that are fully activated, and they're popping up across the country. And hopefully you'll see more information about this soon if you are having conversations with your clinician. So to wrap up here, I want to bring back my pinwheel graphic because I hope I was able to give you, again, a broad view of some of the work that's happening across detection, diagnosis, biomarkers, development of the therapies that are so necessary for everyone, And it really helps, again, to paint a picture of how this all works together. We now have therapies like Aduhelm and Leqembi that target this one part of this pinwheel, this one aspect of Alzheimer's disease. But I noted to you, it's likely to be multiple factors that we need to target to cure Alzheimer's disease because it is such a complex process. And so are many of the diseases that cause dementia. And it's going to be this powerful combination of effective therapeutics that hit many of these aspects of this complex disease, as well as these lifestyle interventions and risk reduction strategies. So there's a lot of more work we still need to do to fill out this pinwheel, but we're making immense progress. One of the things I did want to note to you is that you're seeing me before our international conference. It's about to happen in July in Philadelphia. And this is the largest convening of dementia scientists in the globe. Last year, we had over 11,000 researchers participating in our Alzheimer's Association International Conference. We call it AAIC. And it's really an exciting time for us to learn about all of the new discoveries, for researchers to share their results, and for us to be able to have really important conversations about where are the gaps, where do we still need to fill in information. And one of the things that I wanted to let you all know is that there will be an opportunity for the general public to participate in AAIC. And the chapter will have more information for you if you're interested in learning more about this, but it will be happening on the Thursday, I believe it's August 1st of AAIC, and it will allow you to participate in person or online. And you can watch some of the key highlights of AAIC and learn from some of those scientists directly about the amazing progress that's happening. So I'm really looking forward to this, and hopefully I'll be invited back to give another talk, maybe after AAIC, to share more. And so I think in summary, I just want to note to you all, it's really an exciting time in research. We've never had momentum like this before in our field. And I can tell you that momentum feels palpable when you're at our conference and when you're having conversations with researchers. There's a paradigm shift going on in how we diagnose and even stage Alzheimer's disease. New guidelines for clinicians are in development today. There's new tools for detection and diagnosis. There's new approved treatments that I just talked about today. And there's a growing diversity of therapies under investigation. And real-world evidence, real-world data. This is our new frontier and where we're moving. So it's a new era for us, I think, researchers in this field, and for clinicians who are working with all of you. And I hope that you'll continue to follow the work that we're doing. I hope that you'll also realize that we are here as a resource for you in many ways. You can learn more about the Alzheimer's Association at our website. You can learn more about the research that's ongoing in the space, also on our website. You can join a clinical trial if you want to participate through Trial Match. And you can always contact us with any question you have 24/7 through our helpline. And I have to tell you, this helpline has changed lives. It's changed mine. I've used it multiple times because I'm a researcher and I've had to learn how to be a caregiver myself. And nobody trains you how to be a caregiver unless you ask those questions and unless you fill yourself with knowledge to help you and your family and friends along the way. So I really encourage you to use our resources as much as you want. It's all free. So I'll leave this up while I pass it over to Doris Fildor, who's, I think, going to help move us on to our next section of the meeting. So thank you so much for listening.
Thank you, Dr. Edelmayer. Hi, everyone. As she said, I'm Doris Fildor. I work with the amazing team at the New York City chapter. You may have received an index card and a pen. So please write your questions down for Dr. Edelmayer, and we will have some time at the end to ask questions. So capture some information now, write it down now, because we have two amazing presenters coming up and you might forget between the two. So I invite you to capture the moment. So I have the pleasure of introducing our next two speakers from NYU. Oh, wait a second. Michelle, you told me to say something else. Let me check my phone. I'm sorry. Too many things going on. Okay. Write questions down. Thank you. So I am going to first introduce Dr. Sakina Tall. We have had the pleasure of working with Dr. Tall in a few capacities and so excited to have her here today. She is going to speak on Alzheimer's disease and related dementias, caring for the most vulnerable. And I'm just going to give you a few notes about her. Dr. Tall is a geriatrician, a clinical associate professor, at the Division of Geriatrics, the NYU Barlow Center, Center of Excellence for Alzheimer's Disease, and the New York City Health and Hospitals. Where's my notes? And at the New York City Health and Hospitals Bellevue, where she recently launched a telemedicine cognitive geriatric program. We should talk. Dr. Tall's areas of focus include Alzheimer's disease and related dementias, delirium, multimorbidity, polypharmacy, and advanced care planning. She is the co-chair of the Health and Hospitals Geriatric Council, the New York Council of State Affiliate Representatives of the American Geriatric Society, and a fellow of the American College of Physicians. Please help me welcome Dr. Tall.
Thank you so much, everyone, for being here. It's a pleasure to be in person and to talk about Alzheimer's disease and other dementias. And I practice at NYU. This is what I do almost on a daily basis with my colleague at Masurkar. I will try to go faster and catch up on time so we can have time for some questions. Dr. Edelmayer did a wonderful job covering some of the part that I would have done. Thank you. Okay, so I have no conflict of interest. I will not.
Would you want to use that? Oh, yeah,
No, this is good. I will not go through numbers because we have heard already some numbers. So what I want to cover first is we know that age is the greatest risk factor, a non-modifiable risk factor for Alzheimer's disease, and there are some other modifiable that we heard. But age is not really what matters, as is also the level of function. I would like to share very briefly two cases. The first one is 72, pretty young with multiple comorbidities, poorly controlled hypertension, diabetes, stroke, heart disease, lung disease, kidney disease, osteoarthritis, cognitive impairment, I could say Alzheimer's disease, limited mobility, lives with a daughter and needs assistance with all activity of daily living. The second case is an 86-year-old male, lives alone in the community, very active, well-controlled hypertension and diabetes, works part-time, sees friends, and play tennis on weekends. So that shows how the level of function is really important when we take care of patients. So we covered earlier the definition of Alzheimer's disease and other dementias. Sorry. Okay, so this is not working. I'm sorry. So Dr. Edelmayer covered what is dementia. So decline on baseline of cognition affect different domains. Doesn't have to be only memory. Could be memory, language, executive function, behavioral symptoms that affect the person activity of daily living. And this is what we will call, after full assessment, dementia. It shouldn't be in the context of an acute medical illness. So when we talk about Alzheimer's disease, the pure form of Alzheimer's disease is rare. The mixed dementias are the most common one. In 30%, we have a mixed Alzheimer's disease and vascular disease. And that is why it is so important to take care of not only Alzheimer's disease, but also other risk factors, which are cardiovascular risk factors. So this graph shows that in 30% of cases of the mixed Alzheimer's disease and vascular dementias, you have Alzheimer's disease, other dementias, Lewy body, frontotemporal dementias, and the mixed type. We differentiate the non-neurogenetic disorders, vascular, and those that are more progressive. And the most common one is Alzheimer's disease in 70 to 80% of cases. So there are studies that have shown that Black and Hispanics are more likely to have Alzheimer's disease compared to white individuals. And when breaking down the studies, actually it has been shown that it's more the socioeconomic factors that play a role here. Taking the Black population, you can see a large heterogeneity actually in the prevalence, going from 10% to 20% in certain populations. The prevalence is about 10% in whites, 14% Hispanic, and about 18% in Black. But again, taking into consideration the socioeconomic factors are important. Clinical trials are looking more into genetics, the genetic contribution of gene mutations in Black and Hispanic. And as Dr. Edelmayer said, we need more representation in trial to be able to understand what that really the genetic contribution for Hispanics and Black population. So what happens when we see a patient at the memory center? And earlier we heard that it's not only about a scan or doing a blood work, it's really an overall assessment. It starts with a full evaluation with the history. What is the real cognitive concern? Is it all about, is it memory? Is it language? Is it executive function? When did it start? How is it progressing so far? And how is it affecting the person function? So taking a very good history is important to be able to understand why. And is that a cognitive impairment? Is it dementia? Or is it an acute medical condition that is happening? So a good history is key when we assess patients for dementia. Second, after getting history from the patient and also from the family members, because it's important to have collateral information. Some patients might not have an insight on the deficit. They may not feel that they're having memory difficulties, but people around them are seeing that things are different. So we always ask a patient to come in with a family member or a very good friend who could let us know what is happening. So very good history is key. Then we will go and we'll do a cognitive test. We have some office-based tests. The test that we use should be adapted to the patient that we are serving. So when I go in a room, I do not know yet which test I will use because it depends on the culture, depend on the education level, it depends also on the language. So the test should be adapted to the patient that we serve. Some patients are misdiagnosed with dementia just because we're not using the correct test. Some people are diagnosed with dementia, but instead they are having hearing impairment, right? So making sure that we are providing the accurate assessment is very important. So after we do the test and the test confirms that there's an impairment, we heard some subjective complaints, we do the test and the test is confirmed that there is an impairment in memory or thinking, then we will do the physical examination and we will decide what is the appropriate blood work to do, making sure that we are ruling out anything that we could reverse. We'll decide on the brain imaging that is appropriate, making sure that we are ruling out significant vascular changes, MRI of the brain. We'll proceed with some PET scan, and we have different type of PET scan, as you heard. I will not go further into this. And so the assessment that we'll have is really an overall evaluation and coming up with a plan. Earlier, we heard about how the symptoms, Earlier, we heard how actually the symptoms that we see are actually coming further. So the changes in the brain happen many, many years and decades prior to seeing any symptoms. And when we start seeing symptoms that are proven by the cognitive test, we are in the mild cognitive impairment stage. And when the impairment start impacting function, this is when we talk about dementia. So dementia, again, there are different stages. Some patients could be in the mild stage and will need really assistance with higher level of function. Finances, medication management, traveling far, but they can handle their day-to-day routine. So we make sure that we screen for safety. Some safety concerns will be medication management, making sure that the patient is not taking several meds and forgetting to take important medications. Another safety would be making sure that we cover travel, making sure the patient is not getting lost outside. And also safety concern will be driving, which is a very sensitive topic, and cooking. So the care of Alzheimer's disease is really a holistic care. As we spoke earlier about different factors that are implicated in Alzheimer's disease, it's not only about giving a disease-modifying treatment and hope to make impactful and long-term changes. It's really affecting the overall care of the patient. So making sure that we take care of the non-medication-based and the medication-based treatment, addressing healthy lifestyle. Those are all factors that we are trying to address. The John Alford Foundation has come up with a framework, which is very important when we take care of patients, covering mind, which is memory, mentation, so depression, so screening for depression, screening for memory is important, medication, reviewing all the medication and making sure that there's no medication that is unsafe that could actually worsen memory. Third is mobility, making sure that the patient is actually able to ambulate and walk well. And one is multi-complexity, addressing all the medical conditions. And everything that we do should be in alignment with what matters to the patient. Does it matter for the patient that we proceed with all those testing, right? So everything that we do should be in alignment with the goal of care. So seeing this picture like this could seem simplistic, but it's actually all connected. Medication affect mind, mind could affect medication management. Because of memory decline, people may forget to take their medications. Mobility, sometimes because of limited mobility, patient may not take, let's say, some medication. They may not take their water pill just because they will need someone to take them to the bathroom. Also, mind, a decline in memory and cognition could affect mobility. So everything is connected, and that shows how taking care of a patient with Alzheimer's disease and other dementia should be really in holistic care and taking of the patient as a whole. And when we provide care also, it should be really a partnership between the patient, the care partner, and the physician. Sometimes we have some expectations. We want the patient to do X, Y, and Z, but is it really feasible? What is the social context of the patient? What is the support system? The patient may have a daughter who works full-time, works several jobs. Can the daughter take the patient to all the appointments? Make sure that, or can the daughter really supervise the medication? So really making sure that all the recommendations that we do should be really realistic and taking care of the social and economic context of the patient. So the management, very quickly. One part is the non-medication-based treatment, and the medication-based treatment, I would defer this to Dr. Masurkar, who covered this earlier. Non-medication-based physical exercise, it has been shown before we were saying exercise for 30, 45 minutes. Actually, recent studies have shown that the more you exercise, actually, the better it is. So physical exercise, social activities, social isolation has been shown to worsen memory. So social activity, cognitive exercise. Sometimes we'll be asked, what exercise should I do, right, for my brain? I would say it all depends on what was your interest before, right? Some patients used to like art when they were younger adults. Have them do some artwork. Some people used to do some coursework. Please go ahead and do some coursework. So all the cognitive activities should be actually adapted to the patients. Assess and treat modifiable risk factors. When a patient is diagnosed with Alzheimer's disease or other dementias, actually this is a time that they should keep up with their primary care appointments. Unfortunately, we see a lot of time they stop seeing their doctors, but we have to actually take care of other medical conditions if we want to make sure that we slow down as much as possible the disease process. Treat hypertension, diabetes, cholesterol, and other risk factors. Stopping inappropriate medications, reviewing all the meds and seeing what is inappropriate and making sure we get rid of them. Usually slowly, but that would be the goal. Address safety, we spoke about that. Share community resources, and Alzheimer's Association, Caring Kind are very good partners of us, so we are very grateful to have them. Screen for caregiver burden. Having a patient is not just the patient, but also the caregivers. It's taking care of whoever helps the patients at home. Discuss the disease and making sure that we all understand what is happening and what is the plan for the future. Pharmacological management, medication, we'll be talking about that later. Prevention, we heard earlier about potentially modifiable risk factors. Addressing one of them only would not make a difference. It's really making sure that we address all the risk factors. And when you see this is a tree, just because sometimes the tree could be high the forest. We could see just one risk factor, but others as important to address. They're all connected, and I believe that it's more like a cumulated effect than a one effect of a risk factor. Even if you take hearing loss will lead to social isolation, will lead to depression. Depression will lead to physical inactivity, obesity. So you could see how all those risk factors could be cumulative and interacting with each other. Hypertension, it has been shown that addressing hypertension in young adulthood is important, as it could lead to significant vascular disease. Sorry, I'm going fast too, so that we can have time for questions. I hope you are still following me. So when we talk about Alzheimer's disease, it's caring for the patient, caring for the community, and being really a care team. In this picture, it's nice to see supportive caregivers here. It's not all the time that we have a patient who comes in with a caregiver. So some of those patients are isolated, but it's really meeting the patient where the patient is and providing the services that are needed. On the top right, this is one of my patients who has moderate dementia. She loves art. At some point, she was admitted, she was not doing well, but now she improved. And I received pictures of her artwork through the MyChart portal from her daughter. And it's nice to see. And this is what is rewarding to her. And this is what we call the quality of life. So again, just to finish very quickly, so it's really a comprehensive evaluation when we assess patients for Alzheimer's disease and other dementias. It's not about just coming in and doing a cognitive test, it's a whole assessment. The management must be holistic, taking care of all the risk factors, addressing the socioeconomic and social determinant of health of the patient, taking care also of the caregivers to make sure that also the patient has all the support that is needed. The prevention should really be multimodal, addressing all the risk factors, including communities and addressing health disparities. We need, again, I will not come back on that, but we need more representation on clinical trials so we can really generalize the results that we have to all the communities. Thank you.
Thank you so much. Thank you, Dr. Tall. One of my takeaways is it's complicated, right? It's not just go in, get a fix. It's a lot of factors to consider, and it's complicated. So I'm going to reintroduce Dr. Masurkar. I always say it wrong. Masurkar. I'm gonna ask him to come back to the podium. He's gonna talk to us about Alzheimer's disease treatment and delve a little bit deeper into the treatment past, present, and future. Dr. Masurkar is a physician scientist with a focus on mechanisms, biomarkers, and therapeutics related to early Alzheimer's disease. He received his MD and his PhD from Yale University and completed both his residency and fellowship at Columbia. At NYU, he wears many hats as an assistant professor, an attending neurologist, an investigator at the Neuroscience Institute, and as he mentioned before, he's the clinical core leader at NYU's Alzheimer's Disease Research Center. So while we bring him up, I'm going to remind you guys about the index cards. If you have any that we're ready to collect, can you just hold them up and we can collect the cards? If you need a new card, let us know, because I do want the questions to be rounded up so that when we bring the panel up, we can be ready to go. So Dr. Masurkar, please come to the podium.
All right, so I have the honor of being the last speaker. Well, I think the prior two speakers have answered everything. I'm not sure. No, so I'm happy to end the talks, and I'll sort of reiterate some of the points that you heard before, really from a lens of Alzheimer's disease treatments, and give a little bit of a historical perspective, at least from my perspective. So I wanted to go over the historical origins of Alzheimer's disease, and then go through the medications that are from the past but still used, the kind of the hot therapeutics of today, including lecanemab, and also a reappreciation of non-pharmacologic approaches. The future, what I think are some interesting new targets. And I want to end a little bit on what we do at the Alzheimer's Disease Center to Advance Therapeutics. So as you heard before, Alzheimer's disease was first described by Dr. Alzheimer in 1906, so a long time ago. And this is his picture here to the left. And that was the patient that he first described it in was Auguste D. And this is her picture. She actually had an early onset form of Alzheimer's disease. She was actually quite young when she passed away. And this is, I think, one of those first illustrations of the pathologic features of Alzheimer's disease. You can kind of see that there are plaques drawn, there are tangles. I mean, he didn't really have the terminology to call it those, but he really had it pretty much described back then. And I don't know what happened, but we didn't really focus on those observations of his for a very, very, very long time. And I think that it was partially driven by technological advances in the sciences that drove the kinds of biology that they were looking at with Alzheimer's. I think there was also a long time where Alzheimer's was considered a psychiatric disease and not really an organic, a disease of the brain. And so, basically in the 60s to the 80s, there was a lot of focus on techniques to understand brain chemistry, the neurochemicals that help brain cells, neurons speak to each other. And I think that really pushed forward the theory of Alzheimer's disease back then. So up until 1980s, Alzheimer's disease was thought to be due to a brain chemistry imbalance, the neurotransmitters that underlie communication. And so acetylcholine was one of the real focus of research back then, which is a neurotransmitter very important for learning and memory. Acetylcholine is reduced in the Alzheimer's brain, especially in early stages. And so there was a lot of work in developing medicines that could increase the amount of acetylcholine in the brain. And that led to medicines called donepezil, rivastigmine, and galantamine to be approved beginning in 1996. And those were approved for all the stages of Alzheimer's disease. They work by blocking the breakdown of acetylcholine at the synaptic cleft. This is the point at which two brain cells communicate to each other, and that's depicted in the cartoon in the bottom left. Now, we still use those, and they're very important and useful for stabilizing memory in the early stages, and they can even help with some of the behavioral and psychiatric symptoms of the disease, but they don't slow down the disease progression. They're not disease modifying. They don't fundamentally attack the amyloid and the tau. And the same could be said for the other medicine that was developed in this time called memantine. It's regarding another neurotransmitter that's altered in Alzheimer's disease. It's called glutamate. So glutamate is a really critical neurotransmitter in the brain. It is the primary currency by which brain flow occurs. It's how information is transferred from one brain area to another. However, in advanced Alzheimer's disease, there was a thought that there's too much glutamate. The glutamate is perhaps being secreted by the dying brain cells of Alzheimer's, and then it becomes damaging, it becomes toxic, or it overstimulates the brain areas, causing cognitive issues. And so memantine was developed, which blocks the effect of this excess glutamate on the brain. And specifically, it's a blocker of the NMDA receptor, which is one of the proteins that glutamate works on to exert its effect. So memantine was approved in 2003 for moderate to severe Alzheimer's dementia. And again, while it's still used, it does not slow down disease progression. It's not a disease-modifying drug. So where do we go from here? Well, the last, I would say 30 years has focused on the amyloid hypothesis, which was touched upon by Dr. Edelmayer's talk. And so, so what led to this hypothesis was the development of a lot of evidence that built up a theory that amyloid was the first trigger for the subsequent biological events in Alzheimer's disease. And this figure sort of summarizes the sequence of events. So this is a very famous figure in our field. So the x-axis, the horizontal axis, is the stages of the disease, and the vertical axis is the degree that this biological marker is abnormal. And so the very first biomarker that increases is amyloid, followed by the tau, followed by changes in brain structure, that's the third green curve, followed by memory decline, followed by clinical function. So it seemed to be, from advances in testing, a lot of the imaging that Dr. Edelmayer went over, that amyloid was the first trigger for tau and subsequent neurodegeneration and decline. Furthermore, advances in biology, basic biology, allowed us to determine that genes for Alzheimer's disease are in the amyloid production pathway. Putting those genes in mice recapitulates the amyloid deposition in their brains. And therefore, it was a logical question to ask, well, does reducing amyloid early on impact decline? And that led to the clinical trials. Now, the clinical trials for a long time, as you may have learned by following the news over the last 20 years, didn't work. And they didn't work for a variety of reasons. One is that they probably recruited many patients that didn't have Alzheimer's disease as a primary cause, because we didn't have ways to accurately diagnose people with PET scans and spinal fluid as we do now. Secondly, the trials focused on late stages. And the problem you can see from those same curves is that by the time you pick patients who have dementia, all of these curves of amyloid and tau are already peaked. They're already peaked, and it's very hard to make them go backwards. Or even if you can do that, they've already exerted their domino effect. And so the recent trials have recruited patients, one, based on evidence of amyloid and tau, based on PET imaging and spinal fluid analysis, but also have really focused on the earliest stages, mild cognitive impairment, and even trials focusing on individuals in the preclinical stage, the asymptomatic phase. And so that led to lecanemab. Lecanemab is the first fully approved by the FDA medication to modify Alzheimer's disease at a basic level and slow down progression. So what is it? So what we learned is that amyloid is actually quite heterogeneous, and there's a lot of different kinds of amyloid, and this is a very complicated cartoon of all the different forms of it. And a lot of the trials were targeting different forms of amyloid and didn't work. So this drug actually targets a specific form of amyloid that's soluble and non-aggregated. It's not the clumpy kind of amyloid, it's the more basic kind of amyloid. And it's an antibody that is given through the IV. And the trial concluded in September of 22. There was a trial that was for 18 months for each patient, and they got an infusion every 2 weeks. And the data showed that this slowed down the clinical decline by 27%. So again, it's not a cure, but it's a slowdown, and it doesn't make people better either. So it's a modest reduction, and it's a step forward in the right direction. Additionally, brain amyloid was significantly reduced by the drug, up to 50 to 75% on average. There are side effects. One of the main side effects of this new drug, and all the drugs in this class, this anti-amyloid antibody class, is something called ARIA, amyloid-related imaging abnormality. So what is it? It's either brain swelling or edema, which happens in about 13% of patients, and brain bleeding or hemorrhage, which can happen in 17% of patients. And there's some variability of those percentages based on some genetics, but this is a concern, right? We don't know the long-term effects of these side effects. We don't exactly know how to predict who's going to get them. Nevertheless, the benefits seem to outweigh the side effects from the FDA's perspective, and it got full approval in July. And now we have the first fully approved disease-modifying therapy for Alzheimer's, with more on the way, as you heard from prior presentation. The other thing that I think that is important not to forget are the non-pharmacologic approaches. I think we forgot about those. We were chasing amyloid, we were chasing the science, and we forgot about these tried and true traditional methods. And I wanted to briefly go over these because I think there's something that me and my colleagues really want to utilize in our patient care. Exercise, aerobic exercise. We know that it increases blood flow to our memory centers, it improves mood and sleep. Again, how much to do, we don't know, but about 20 minutes a day is good. It doesn't have to be super intense, but a little bit can go a long way. Socializing. When we socialize, our brain releases very positive chemicals for brain health. It helps us maintain focus. It helps us be oriented by having a social schedule. So we really promote socializing. Diet. There are a lot of different diets out there that have been posited to be helpful for the brain. I think the one that has the most evidence is the Mediterranean diet, which is really focused on lean sources of protein like chicken and fish, olive oil, legumes, greens. And there has been evidence to show that it leads to less atrophy or shrinkage of the memory centers. And of course, it's also good to watch out for excess salt and sugar and ensure good vitamin intake, especially B12. Cognitive stimulation, as Dr. Tall brought up before, I think it's good to do what you like, do a variety of things too, try something new. And it's better coupled with socializing as well. And it helps our brain develop new strategies to solve problems. And then lastly, I think we're really appreciating the importance of psychosocial interventions. And these can be stress reduction approaches via counseling or mindfulness for possible prevention of dementia or even slowing down the progression. And then you have caregiver-centered or patient-centered approaches to help manage not only the cognitive issues, but the behavioral symptoms of Alzheimer's disease and related dementias. And these can include art therapy, music therapy, reminiscence therapy. And I think this is a very hot topic now. And we're trying to balance these approaches with some of the more modern medicines. So where do we go from here? I'm going to talk about 3 targets that I personally am very excited about. One is tau. Tau, we know it actually relates better to Alzheimer's symptoms, where it is and how much there is, and its progression. It sort of delineated the progression of tau in the cartoon at the bottom right. It may directly result from amyloid. It's sort of the second domino, if you will. It is challenging to target it because it's inside the cell and it's hard to give a drug that's outside the cell to target something inside the cell. And I think this is why the trials haven't been successful thus far. However, I think that understanding how amyloid or other processes lead to the tau accumulation will really enable us to develop better approaches. The second one is immune and inflammatory processes. There's a wealth of research now that the immune system can be good or bad in Alzheimer's disease. Very early on, it may have a positive effect. Later on, it may have a negative effect and actually potentiate the impact of amyloid and tau and buildup of those entities. And so trials are underway to investigate how to positively engage the immune system early on, for example, through vaccine or immune system boosters or adjuvants, or prevent specific inflammatory pathways that occur later in Alzheimer's disease. And this is called microglial biology, microglial responses. And the last one that I wanted to mention was the synapse, that communication point between brain cells, which I've sort of depicted by the cartoon here. So synapses, these connections, really facilitate the communication between one brain cell and another that really lead to cognitive function and action. And in Alzheimer's disease and all the other dementias, the end-all be-all in the brain really is loss of synaptic function and their degeneration, which then subsequently leads to the brain cells dying. And so research on this process and that synapse loss in Alzheimer's disease has opened up new targets that protect the synapses from the effects of amyloid and tau. And what's intriguing to me about this biology, this area, is that this process might be applicable to all of the dementias, because that's really the common end of all of these different proteins, whether it's the Parkinson's protein or stroke, et cetera. So I'm very excited about this branch of the field. And so I lastly wanted to finish up with what we're doing at the NYU Alzheimer's Disease Research Center. We're one of 30 centers across the country that were established initially in the 1990s by the National Institute of Health to facilitate collaborative research on Alzheimer's disease and related dementias. And we pool our data. And so there's over 30,000 persons worth of data longitudinally for researchers around the world to use. Our center has really focused a lot on very early stages of Alzheimer's disease. We've pioneered the staging approach to Alzheimer's disease. We've developed concepts around the preclinical stage of Alzheimer's. We developed widely used methods to evaluate and monitor symptoms of Alzheimer's disease. We've played a critical role in advancing the use of imaging to diagnose at preclinical and MCI stages. And our work is really centered on a long-standing longitudinal study of about 500 older adults who come in every year for yearly evaluation with cognitive functional imaging, blood, and other tests. And this is a picture of our wonderful group at the bottom right. And so what are we doing with respect to the therapies? Well, we really are focused on detection, tracking and prediction, and using that information to develop new targets to stop and slow down Alzheimer's disease. And so we are developing more cost-effective and less invasive ways to detect and track at-risk patients, for example, through the blood biomarkers that you heard about before. We're researching new ways to predict who might be vulnerable to that side effect, a lecanemab, ARIA. We are looking into the biology of tau very closely so that we can uncover new drug targets. We're studying the immune system and engaging it in clinical trials to treat early Alzheimer's disease. We're figuring out why synapses die or become dysfunctional in Alzheimer's disease and trying to come up with potential protective agents for that process. And very importantly, we're examining how those psychosocial and lifestyle approaches actually can impact Alzheimer's disease at a biological level by looking at how they affect biological markers and outcomes of Alzheimer's disease. And so I'll stop there. Looking forward to questions and wonderful discussion with my two other speakers.
Thank you so much. So we are going to ask the speakers to all join back up on stage. Okay, so there's a lot of questions. We're not going to get to everyone's question. I'm gonna say that out loud first, okay? I will try my best.
And I just to add one thing, for those of you that have joined us via Zoom, we have recorded, those questions are in the mix as well. So our online attendees, your questions are included.
Thank you. I do want to also highlight that there are a number of resources outside. We've invited Sunnyside Community Service to join us today. They also provide support to patients and families. Our group is outside and the NYU Research Center is outside. So there will be time at the end to learn more about specific research happening here, to register for it, and to learn about different programs. So the first question round is going to be focused on the clinical trial piece. So a simple one, Dr. Edelmayer, how did they come to the number of people that they need to participate in the clinical trials of 66,000?
So, can you hear me? Okay, no. Thank you, we'll share. Thank you so much. So the way that particular report is done is that it uses information from a website called clinicaltrials.gov. So that's where many of the clinical trials across our country are actually registered. And each clinical trial is designed in a different way. And each clinical trial is designed in a way where it includes a certain amount of people that need to be recruited and enrolled to be able to study and get answers out of that particular study. So I think what the report is doing is it's actually adding up out of that, I think 167 trials, I think maybe were on there, how many people are needed to actually complete those studies. So if a study requires only 50 people, that's added to a study that requires 1,800 people, or a study that needs 300 people. So that's where those totals come from across all the phase 1, phase 2, and phase 3 clinical trials that are being done in Alzheimer's disease. But I want to caveat that it's definitely more than 65,000 people, because that is a very particular analysis of data, just looking at Alzheimer's studies. And it's only really extracting the data around using the term Alzheimer or dementia in the study. If a study is being run, like a lot of really important phase 1 studies or even phase 2 studies that are early, and maybe they're studying inflammation, like one of the really interesting new avenues of research, it might not use Alzheimer's or dementia in the trial, but it's still being used to test hypotheses associated for Alzheimer's and dementia treatment. So there's definitely more than 65,000 people needed, probably closer to at least 100,000 people for sure, or more.
So we're going to stay on trials for a second. I'm going to try to make it a 2-part question. One, in terms of representation, we know there's a very smart person in the room who read our who was at AIC last year, and they said that the Bronx has the highest prevalence of Alzheimer's disease. It has one of the counties with the highest prevalence. So what is being done to recruit and work with people in the Bronx? And the part 2 is looking at representation as it relates to that. Someone asked about communities of color, particularly Asian Pacific Islanders. It's not very easy to participate in clinical trials. So how do you access trials when they're not in your region or in your area? So we talked about NYU has it, ALZNet in the Bronx where there's the highest prevalence, or other communities, they may not have access. So how do people get involved in clinical trials if they're not in the area?
Yeah, so in terms of our local center, I think it's so critical to engage with these communities that are at highest risk. And what we have been doing over the last few years is trying multiple approaches. One is going out in the community, doing presentations, setting up health fairs where we can really engage people directly and listen to what they are looking for. Maybe even describe what we can offer both research and clinically. That's one way. The other way has been aligning with community organizations such as churches, who can be, who can align with us to really also instill confidence in the communities that we're doing good work for them. A third way is that we have established community advisory boards that are really focused on these communities so that we can hear from their leaders what are those populations' concerns? How should we approach research and trial communication there? And then there are multiple other methods through the electronic medical record, through the internet, et cetera, that we can utilize to engage and advertise about research.
Thank you. So there's another question in terms of clinical trials. So for people who have moderate or advanced stages or another chronic illness, are they able to participate in clinical trials? And is there any trial about reversing dementia?
So when we talk about the staging, moderate to severe dementia, it depends what we are trying to achieve, right? If it is, you have some behavioral or non-pharmacological approaches, such as exercise, diet, we know that those are beneficial. What we heard earlier about potentially modifiable with factors, all those are important. So the stage of dementia, I would say, depend on the target and on the trial. A lot of the trial really look into early stages, but you could have other trials for later stages. And Alzheimer's Association has like a match website where you can go and enter your intervention, your information, and you can find the correct trial for you. Again, it depends what you're looking for.
So there's another question. I'm going to answer that with Dr. Tall's answer. Someone asked about if you don't have dementia, if you have family history, if you are younger, go on Trial Match. They will match you based off of your risk factors. And then the research study will also do an additional assessment to see if you are eligible. So I'm going to stick with your point. There's a question online about progression, and there was the chart that you shared talking about 20 years before you see some warning signs or some 20 years before you see any symptoms, people may be developing amyloid. So there's a question about the timeline. Does it take from the earliest stages to cognitive function, the earliest stages of impairment to impacting function? I hope I said that right.
So everyone is different in terms of progression. There's no linear progression in terms of Alzheimer's disease or dementia, and some patients could even skip stages. When we talk about, let's say, mild cognitive impairments, we are seeing symptoms really when people can no longer compensate for the changes happening in the brain. Some people can compensate for a long time because of the brain reserve. So it's really difficult to put like a timeline in terms of like staging and progression. What we know is other factors could interfere. Someone who has very limited risk factor, who is physically active, might be able to compensate for longer time compared to someone who has multiple comorbidities, vascular changes, strokes in the brain, and other medical conditions. So again, there are many factors that are interacting. So the progression depends on all those factors. Do you want to add anything?
Yeah, I would agree. It's that progression from normal to mild cognitive impairment is so variable and can be extremely slow. I don't think we have a good handle on being able to predict that. And we're not good at even predicting the MCI progression to dementia either. There are certain obvious factors, but that doesn't explain all of the variability from person to person.
And I liked the term that you used in your talk, this sort of holistic approach to how we're understanding what's going on with our bodies and our brains across a life course and how that might impact. And there's a lot of very active research ongoing, trying to understand reserve and resilience associated with our brain health, if you want to use that term, brain health, and what is going to be best, again, for each individual. So people are always asking us, like, what should we be doing to improve our reserve and resilience? We don't completely know that perfect recipe yet. But some of those things I think was in your tree slide, I think is really good. We're looking at all of these factors and trying to understand, because we're trying to study the biology associated with that too. How does it impact somebody's progression or severity of their symptoms too?
Thank you. I do want to highlight that, oh gosh, I forgot what I was going to highlight. I'll remember later. There's so many. I think I need a screening. I'm sorry. Dr. Toll.
No.
There's so many good questions. I'm trying to get to all of them, and I have my own questions. But let me go to this one. In terms of screening, is there early screening if there's screening available for younger adults? And what screening tools should be used by healthcare professionals that are simple?
Okay. So the screening depends on the patient that we are really assessing. I think it's wrong to just screen widely, just because all the tests, so one size doesn't fit all. For example, some tests are validated for, let's say, more like white population, and some others in more culturally diverse population. So I would say it really depends on the patient that we are seeing here. There's no recommendation to screen across the board. There are some indication patient with diabetes is recommended to screen just because of the high risk of developing cognitive impairment. So we don't recommend specific tests across the board. If you see your primary care physician and you do have concerns regarding memory or thinking, more history should be taken, and then the appropriate test chosen then.
NYU actually has a center focused on early detection and working with primary care. The Alzheimer's Association also has a number of resources for primary care to begin the process. So a follow-up question to that is, if I'm concerned about my brain health, how do I get treatment? Should I come to the memory center here at NYU, or can I go to any random neurologist?
Well, I would actually say start a conversation with your primary doctor first, because oftentimes there may be very, very simple and treatable reasons why you might be having feeling like you have memory problems, and they can usually screen for those, like depression, or if your diabetes is a little bit less controlled. Those are all things that are readily fixable. But they will know if it's a little bit more than that and it needs an expert's opinion, they can help you make that referral. They can help you make that step.
Wonderful. And if people want specific information about NYU, again, they have a table outside that you can share more information about the research happening here. So now there are some questions focused on risk factors. So there are questions around trauma to the brain, concussions. So I guess the question really is focused on, what are some of the primary other kind of risk factors, if we can talk a little bit more about risk factors and its impact on developing Alzheimer's. They have obesity, concussion, brain trauma, family history. So if you can say a little bit more about any of those.
I think each of those is worthy of a talk.
You're like, yeah.
So what you want to know that those risk factors are not necessarily causal, right? It doesn't mean that because someone has traumatic brain injury, they would develop dementia. So those are risk factors. They could increase the risk of developing the disease. Traumatic brain injury, there are a lot of studies looking into it. How much injury is needed? Like, is it moderate, severe? Was it did the person pass out or not? So it's not just like banging your head, and that we would call a concussion. Sometimes it's also overdiagnosed. So again, all those risk factors, as you said, could be potentially increase the risk of cognitive impairment.
And I'll comment just on the family history part of it, which I think you could probably say is a genetics question, right? So if my mother or father had dementia, am I at higher risk? And I think the answer is I don't think as much as we used to think, because one is that we know that it's being diagnosed much more commonly, and just like other diseases, once a disease is diagnosed, becomes more prevalent, then it kind of waters down the sort of genetic thoughts about it. The second thing is that there are risk factors for dementia that you can inherit from your parents, but they're not deterministic. They move the needle a little bit, but not in an incredible amount. And then you also have other genes that you've inherited that move the needle the other way. So I think family history is important to note, but it is not definitive. There are some very, very rare genes that run in families that cause early, young onset dementia, but that's very rare. And you would see it in half of each generation.
Wonderful. So there's a question around ALZNet, Dr. Edelmayer. Does ALZNet collect data on people who are diagnosed but do not enroll or are accessing some of the new treatments?
It actually is capable of doing that right now. Our goal with ALZNet is that we expand data collection for people eventually who are even just starting to seek care, maybe even from primary care clinicians, but we're not at that point yet. We had to sort of start somewhere to build this network. So right now, for patients that are being seriously evaluated or even initiate treatment or have previously initiated some of these new treatments, can be enrolled in ALZNet. I can tell you though, there's a number of patients that have been enrolled who have either chosen by themselves or with their doctor's decision to not initiate a certain treatment, even though they've gotten a diagnosis, and we're still continuing to follow them. There are some patients that started treatment and have already stopped for one reason or another. So the goal with ALZNet is that we should be able to follow people through all of that decision-making. And it's not under sort of the pristine environment of a clinical trial. People miss doses of their medications. People are on vacation. You need to live your lives. But all of that is being done through ALZNet in a way that can be done in that way, so that it's not like a clinical trial. We can follow people for longer as time changes and as your clinical decisions change.
Okay, thank you. So if I have a loved one who's on a medication such as donepezil, how do you know if it's working?
So it's a good question. I think when we initiate the treatment, it's important to set expectations. Fortunately, a lot of times people are given this medication without much explanation, so they hope that the memory will improve. So this is not meant to improve memory. It's meant, as was explained by Dr. Masurkar earlier, it kind of helped the cells to talk better to each other so that the messages could go better. It's meant to try to maintain function longer. So it's not something that we can measure. What I will explain is we are giving this to hope to maintain the function as long as possible. As long as there's no side effects, we'll continue the treatment. And this is how we'll continue to monitor, and we'll add eventually memantine later on, which has been shown together with the Donepezil to be more effective.
Wonderful. So I'm going to wrap up the question and answer right now. Thank you, panel, for your answers. If your question wasn't answered, I'm sorry, but I tried my best. We do have a few more minutes for you to meet with each other, to look at the tables outside, to meet with our presenters. So if we can just thank them again. And Michelle is going to wrap us up.
Yes. So as we're wrapping up, we want to make sure that you know where you can reach out to get more support today if you need it. You've seen these numbers and this website a couple times. Oh, and it's not showing, is it? Okay. I know. No, it's not. There it is. Okay. Now you're seeing it again. We want to make sure that everyone in the room is aware of the Alzheimer's Association 24/7 helpline. That information is here on the slide, and our website is also has a wealth of information on a range of topics, from care and support related topics, ways to get involved with us as an organization, and ways to learn more about research. So as we wrap up, we just want to again thank all of you for attending. There's clearly such interest in this. Those of you in the room is still full at 7:52. So thank you all for sticking with us. Thanks for those of you online for joining. Thank you, NYU, for hosting. Thank you to our wonderful speakers. And I will ask, and we'll send this out a couple times, but this link up here, the QR code is on your agenda that you took out up on the screen. It'll be outside, and we'll send it in an email as well. But we really would appreciate you giving us your feedback on today's program. We're really excited to be back in person. We haven't done something like this in person in a few years. So it feels like it was quite well received. We want to hear what you want to hear about. So thank you all. Grab a drink, grab a snack, and have a wonderful night.